Our live online weight loss surgery seminar. My name is Jesse Gutnick. I'm one of the bariatric surgeons here, and we've got a great panel made up of from people from our department, some other surgeons, medical providers, and nursing, and also a patient of ours. We're going to have a question and answer session at the end, but you can submit questions all throughout the entire program by sending it to the Q&A, but we'll address those all at the end. And sometimes I combine a couple of questions if they're similar. So if you don't hear a question that's exactly the way you answered or asked it, I may have combined it with someone else that had a very similar question. Kind of to give you a roadmap of the presentation today, we're going to hear from Jamie, who's both a nurse in our department and a patient of ours, and we'll hear her story. We're going to talk about how effective weight loss surgery is, how it's safe, and then what to expect if you choose to get weight loss surgery care with us. Then we'll get into our Q&A. Like as I said, you can submit them via chat and send them to all panelists, and we'll be looking through them as we go and then moderating it at the end. So with that, I'd like to hand it over to Jamie. If you could pick things up.
Hi, everybody. Thanks so much for joining us today. My name's Jamie. I'm one of the nurses that works here at the Bariatric and Metabolic Institute. I've been working with our current team for about 4 years now. And I experienced my weight loss journey in its entirety through this department. And I set up a little presentation to kind of talk about just what I've gone through and my story. Next slide. So the picture on the left is me at my highest weight in September of 2019. I'm right there in the center. And then the picture of me on the right is in September of 2020, 1 year later. And that's the bariatric surgeon that did my surgery, Dr. John Rodriguez. He's no longer with us. He's at Cleveland Clinic, Abu Dhabi, but he's just one of our many great, highly skilled surgeons that we've had the privilege to be able to work with and that are continuing to help our patients. Next slide. So I'll just present a little bit of my information for you. So prior to bariatric surgery, I was about 34 at the time that I had surgery done. Like I said, my highest weight was 253 pounds. I was only 34, so I didn't have a lot of significant comorbid conditions or high risks associated with obesity. I really just had polycystic ovarian syndrome and infertility. However, I do have a strong family history of obesity, both sides, but more specifically on my maternal side, there's a family history of diabetes, a lot of joint and back issues. My mother really struggled with obesity her entire life. So growing up as a young woman, I really saw my mom's struggles and, even emotional struggles of her and her challenges of dieting and exercising and just trying to lose weight throughout the years and it not being effective for her. That played a really big role on my decision making as a young person or younger person and how I wanted to make my, choose what I was going to do to help me not struggle with my weight. I had considered bariatric surgery prior to even working here. I knew that that was something that was available and things that, I hadn't ever heard any of the bad stories about it. I just heard like the negative kind of concepts about bariatric surgery. And, I got a lot of times like, oh, you don't need that. You're fine. Just, lose diet, exercise, you'll lose weight, that kind of stuff. However, I was doing that and it was really not working for me. So once I started working here, I learned more about bariatric surgery, the safety of it. I got to know my surgeons. I got to know really just what kind of value it has and how it can affect my life in a positive way. And so I decided that I wanted to move forward with that. I had bariatric surgery on December 13th, 2019. So I'm officially 2 years post-op. My current weight, I range about 155 to 160. It just kind of depends on, how well I've been eating, how much water I have, those kind of things. But I've been pretty stable within that 155 to 160 pounds for about a year and a half now. So maintaining has been a really big deal for me, that I'm not like worrying that I'm like regaining my weight right now. My approximate time in surgery total was about an hour and 20 minutes. And then I spent about a day and a half in the hospital. After I left the hospital, my recovery process, I had about 3 days of like, you have real post-surgical pain where you're going to be taking some, additional pain medications, that kind of a thing that were prescribed, and just knowing like I'm going to be a little sore from surgery. After that, it was really just Tylenol as needed, and just kind of taking it easy, making sure I'm doing what I'm supposed to be doing with, getting fluids and that kind of a thing. I was really able to move around and walk pretty well within the first 3 days. So mobility wasn't really a factor in this. It was more of just kind of that abdominal. You just had kind of like a laparoscopic surgery on your abdomen. And so you have a little bit of soreness and tenderness from that. And I was actually back to work within 4 weeks after surgery. Literally on like my 4th week of surgery, I started working again, and I really did not have any further issues. It was more of just a matter of me managing my diet and getting proteins and adequate health. And I'll talk about that more in the next slide. Oh, I'm going to actually talk about medications first. So this slide actually, it kind of shows you what my weight was over the course of the time that I actually worked here. When I first started, I started doing medications to try to lose weight. And then it kind of shows you how effective the medications were versus surgery. So the line that's purple is actually like what my weights, my documented weights are within Cleveland Clinic. The box in the red is when I first started actually working towards weight loss with the addition of medication and just like a provider assisting me with weight loss. And so I began taking a medication called phentermine and also a medication called metformin, which was to help treat the PCOS and kind of regulate my blood sugars and things like that. You can see I lost a good amount of weight initially. My starting weight was 243 pounds and I got down to about 220. And so I lost a good amount of weight. But with the phentermine, it makes the state of Ohio requires you to stop the phentermine for about 6 months. And so you kind of go on this little hiatus from it. And so maintaining that weight loss was actually a really difficult problem for me. So by the time I could start the phentermine cycle again, I was still on the metformin, but you can see I already started kind of gaining weight back. I started at like 225, and you can see my weight didn't really necessarily go down. It continued to kind of go up a little bit on that scale. So it wasn't really as effective that second time around. By that point, I kind of was like, oh gosh, like nothing's going to work. I've been trying to do everything I can. So I kind of, slipped back into that. Like, I'm just going to do what I'm going to do. And you can see my weight went all the way back up to my highest at that point, which was the 253 pounds. But by that point is when I knew I was going to start having surgery or prepare for surgery. So that's that blue box, the number 3 box. That was me at my highest weight. And I began another cycle of phentermine. And I was still taking the metformin. And really that was just, I'm going to start this so I can start losing weight prior to surgery and continue to have that weight loss as I go through the surgical process. So the arrow arrow letter B, that was actually my weight, 240 pounds, right when I started the pre-op liquid diet, which is a diet that most people go on right before surgery for about 2 weeks. And it's mostly protein shakes. It's discussed with your nutritionist as well as with a nurse coordinator what protein shakes are going to be best for you. And, we do educate our patients on that, but there is a 2-week liquid diet for most patients. And so it did help me to lose a little bit of weight. So right the day of surgery or day before surgery, I was about 233 pounds. And then you can see as of July 21st, 2021, that was my most recent date weight that was put in this graph. And I'm down at about 160 on that graph. And so I've really been able to, since surgery, lose about 100 pounds, and I've been consistently maintaining it off. And so for me, that change, the struggle that I had with weight loss meds and with diet and exercising on my own, it really was not effective. But and even a 6-month break in between, I was still continuing to gain weight. But post-surgically, I've been able to lose that weight and maintain it. Next slide. So these are some of the milestones that I did want to talk about. At about 2 to 4 weeks post-operatively, it's really important at that time to be getting enough protein in, as well as getting enough fluids just in general. You're really not eating anything. So you're pretty much your diet is consisting of protein shakes so that you can get adequate nutrition. And that really is a struggle that first 2 to 4 weeks. That's part of why you do have 4 weeks usually off of work. And it's really to focus on making sure that you're hitting those goals and not getting dehydrated, that kind of a thing. So it's really important at that time to start working towards getting at least one of your protein or water goals in. Also, really at that point, getting up and getting moving. It's really you don't want to do too much as far as like exercise goes, but the walking and things like that really did help me to feel motivated to continue on. Also at that point, my surgical pain was, by the time I was about 2 weeks post-op, my surgical pain was really at a minimum, and it was just kind of, if I was bending over or that kind of a thing, then I would kind of feel a little bit of pull, but on a regular basis, it wasn't significant. At about 1 to 3 months, I was at that point hitting my protein and water goals pretty consistently. I knew what I was doing wrong if I wasn't hitting those goals. At this point, this is when your clothes are starting to fit you differently. And you also have noticeable weight loss to you as well as others. I also noticed my activity level was increasing. So not only was it increasing from just I'm recovering from surgery, but also my ability to do things was increasing as well. I was starting to notice like it's a lot easier getting out of the bed. It's a lot easier, just walking around, taking the stairs. I'm not as winded, those types of things. Just in that short amount of time from surgery, I was already starting to notice that change in how my body was feeling. At 3 to 6 months post-op, I say food is finally your friend again. Prior to that, you're really feeling like, food can be kind of boring because you're sticking to what is the most important things, those protein shakes and making sure you're getting protein in. And it's really, you're just eating to maintain your health and maintain these goals that are set for you. But by the time 3 to 6 months rolls around, then you're finally able to, have a little more variety, that kind of a thing. And so it was a little more enjoyable at that point, food wise. And then also my weight loss at this point was really, really noticeable. So you feel better because you're starting to see people that you maybe haven't seen in a while, and they just can't even recognize you sometimes. And then also like that feeling of like my clothes that haven't fit me in so long are finally fitting me well, or I'm looking good when I, try something on. So to me, that was actually very apparent right at that 3 to 6 month mark. I also, at this time, I really relied on a lot of family support and friends that, I had spoke with prior to let them know I'm having surgery. Some of my friends and family are smaller than me, so it was actually really nice that they actually were able to kind of give me some of their clothing options, so that while I was still losing some of that like a bulk amount of that weight, I wasn't going and purchasing clothes that I knew weren't going to fit me in like a couple of weeks, which does actually happen. And so I encourage, if you do go through with the process, really rely on friends and family for support during that time. At about 6 to 12 months, that's when my weight kind of started slowing down. The weight loss slowed down and kind of became more of just a maintenance kind of thing. So at this point, it was kind of fun because now I knew what my like stable sizes were going to be. So it was fun to kind of go through my clothes and just kind of pull out the stuff that does not fit me anymore. And you just kind of look at it like, oh my gosh, look at where I've been. So that's exciting. Also, food wise, I was having minimal cravings. So that I tell people all the time, one of the first times that a cake ever went bad in my house, it was my son's birthday. And we literally celebrated his birthday. Each of us ate I had a like very small piece of cake. And then my husband and my son, they had, a piece as well. And then it wound up just sitting there. And so even for me, not feeling like I needed to take that and eat it was a big deal. But also it kind of made a change in like my family as well. Like we tend to like just not eat the sweets, even when like sweets go bad, things go bad in our house. So we tend to like we tell people to take this stuff home because we're not going to be able to even eat it. So I really don't even have cravings for some of those things that in my head before surgery, I was really just like, I need like, oh, there's cake, I'm going to eat this. Oh, there's, sweets, or there's carbohydrates, things that you really tend to feel like you need to eat. I don't have that. And it's like, I don't miss it either. So that's kind of nice. I also really noticed at this point a lot of changes in my confidence level. I feel, better about myself. I know physically I look better and feel better, but also just emotionally, I feel like I'm in a better spot. Mental health wise, I feel, happy that I did what I did. And, even my husband, he was supportive of me going through the process. But he was still worried, he did not think that I needed it, kind of a thing. And for him, he was he was less encouraging initially. Like, you don't need this, you look fine, you look beautiful, that kind of a thing. But once I, told him I want to do this for my health and myself and to feel better about myself. And now afterwards, it's amazing. Like we'll see people that we've not seen in a while and he'll be like, look at her, look at this, she looks so great. Things like that, where it's like, even for my husband, he looks at me, differently, as in like, he can't believe the difference. And so that's really kind of been special going through that. And then also I talk about non-measurable goals, things that like you can't really put, like it's not on a scale, but it's things that you can suddenly do that you really didn't realize were a thing before. Like putting on a sock while you're standing, I always say. Before, like my balance was not that great. And so now it's crazy because I'm able to like actually do like even leg exercises, just standing up and standing on one foot. And, you don't have that, you have like these changes where, it's something that really, the amount of weight loss doesn't really measure it. It's the types of things that you're doing, sitting in the car and how far away from the steering wheel you are is crazy. And just that extra mobility that you have while you're, in the car, it's a different feeling. And so I'm really happy for that. We'll talk about the next slide now. So the next part of this, I'm 2 years post-op. And so I really try to, at this point, stress the importance of maintaining that weight loss. I was given this tool to help me lose the weight, but now how am I going to keep my investment in myself that I just did? And so one of the things that we talk about a lot through our program is being mindful of, your protein goals and how much sugar you're taking in and, getting your fluids. Still to this day, I take that to heart and I'm mindful of, how much sugar is in the thing that I'm about to put in my mouth. Depending on the surgery that you have, those types of things can play a different role. I had the gastric bypass. So for me, a higher amount of sugar content and things can actually make me feel a little bit sick. And so I try just to avoid that just in general, because I don't want to feel that feeling. And so I've had to outweigh, is this really worth it for me to feel, not well afterwards? Or, do I want to just have a small little bite of something? And so I, really take those to heart. Another thing that we talk about throughout the whole entire program is exercise. And it's almost like, we will say this time and time again, and every single provider that you're going to see is going to say, well, you need to make sure you start exercising. Exercise is very important, and those kinds of things. Weight resistance training and, cardio is important, but I'll show you in my next slide, proof that this is kind of important. This is one of the things that I really didn't take to heart. I just kind of was like, oh, yeah, exercise. We say that all the time, and it's important. But I didn't really start working out until I was about 8 to 9 months post-op. And it was because my weight kind of plateaued, and I was like, what am I not doing? I mean, I'm active and I was exercising, but not consistently. And so once my weight started plateauing, I was like, why, what do I need to make a change in? And I started doing weight resistance training, and it really, then the pictures that I'll show you will really prove to you why that's really important. And I wish I would have started that a little bit sooner than I did. One of the other things is continuing a daily vitamin regimen. I can't stress this enough. I work with the medical team, and we see patients that, they stop their vitamins for this reason or another, and then they become vitamin deficient, and they, it can cause some issues. And so just making sure that you are taking those vitamins that you'll be needing to take post-operatively for the rest of your life, just being prepared. I was taking vitamins before I had surgery, and I've been taking vitamins since. And one thing I can say that I noticed when I haven't been taking my vitamins, my nails feel a little bit thinner, or my hair doesn't look as shiny and nice. But when I am taking them consistently and doing all the things that I'm supposed to be doing, I really do feel like this is the best thing. And that's really what our goal is, for people to be doing these things so they can maintain this investment in themselves. Another thing that's important is keeping up with your post-op appointments. You get all the way to surgery and you do all these appointments, and then you have surgery, and then there's appointments that you should have post-operatively. And that's really important. It's so that you can make sure that you're getting your vitamin and minerals checked. It's so that you can make sure that, say you are gaining weight, or say you're having some problems with this or that or the other, it's catching that before it becomes some significant issue. I don't know how many times I've heard patients that say, oh, well, my sister or my so-and-so had this done a year, 3 years ago, and they're right back to the same weight. And part of that is, if you come to your post-op appointments, those are things that we might be able to catch before you're back to the same weight that you were. And so maintaining those post-op appointments is really important as well. So next slide. This slide I'm excited about. So this is me, the difference between exercising and not exercising. So in the summer of 2020, I was about 6 months post-op. My weight was between 165 and 170, and I was just stagnant, not really moving. And so but I had lost a good amount of weight. So I was like excited, and I was just riding this like, oh, I've lost a bunch of weight kind of train. But then once it kind of stagnated and I needed to do something, I really started doing weight training and exercising, and I didn't join a gym. This is all from stuff at my house. I have a rowing machine and I have free weights. And so the picture on the right is me the summer of 2021, similar weight, 163 to like 158 pounds. And I really, have actual tone. Like for the first time in like 15 years, you can kind of see some ab muscles, you can kind of see some biceps. And so for me, that was such a change in like actually even being able to work out and noticing like, hey, there's an effect of me working out. And so that's actually what made me feel really, really good. So ultimately, I can't stress enough like how important it is to just to do that exercise, even though you're going to hear it time and time again. But the sooner you can begin it, the better. As soon as you're cleared to do exercise, I recommend that you start. I believe that's it. Dr. Gutnick, if you want to switch to one last slide. Yeah, that's it. So thank you everybody for hearing my story, and I look forward to your questions, and thanks for joining us today.
Thanks. And, I think your story really highlights most of the things that we talk about extensively when we're meeting with patients, and it really sums that up really nicely, especially the beneficial effects of strengthening after surgery. I'm going to talk a little bit about how bariatric surgery works. So, many people have the experience of what I would call transient weight loss. So you take weight loss medications, much like Jamie showed in that graph of her weight, and they're very effective in the short term. But then often you retain or regain that weight as soon as you're off of them. And our bodies have essentially what is a weight thermostat, just like the thermostat in your house, where there's hormones that counteract weight gain and also weight loss, but they're stronger against preventing weight loss. And we'll talk about what those hormones are on the next slide. So when you diet or use these medications, your body actually fights that weight loss by turning down your metabolism. And the reason that weight loss surgery is more effective than diet and exercise alone, or even diet and exercise plus medications, is it actually reprograms how your body manages food. And for about 2 years after surgery, it supercharges your metabolism. Then you get a new weight reset at that point, which is lower. So this is how things differ. So when you're dieting, your basal energy expenditure, or the amount of calories that your body's burn just to maintain living, when you diet, your body changes things, so it turns it down. Bariatric surgery turns it up. We talked about that. The hormonal basis of hunger increases when you're dieting and decreases with surgery. Similarly, your hormonal basis of feeling full or satisfied goes down when you're dieting and up after surgery. Some of your body's stress hormones decrease after surgery, whereas they increase with dieting. And then there's some specific gut hormones that are related in how your body manages the calories, which go in the opposite directions, all towards the beneficial with bariatric surgery. And so many people think that it's just a smaller stomach, and that is a part of it, and that is part of the changing of portions, but it's much more than just a smaller stomach. We're going to talk about what the surgical options are. The most common and historically the gold standard bariatric operation is the gastric bypass. A relatively newer operation is the sleeve gastrectomy. And much of the graphs and sort of scientific studies that we're going to show you are about these two. There's also a third option called the duodenal switch, which is more powerful. And we occasionally need to do revisional surgery for correction of issues or for weight regain, which is a real thing, but we try to minimize it through our follow-up. Just to give you a sense of what these operations are, the gastric bypass is on the left, and all gastric means in medical terms is stomach, so the majority of the stomach is bypassed. That makes that small pouch out of the top of the stomach, which is helpful for portion control, but also by bypassing the stomach and the first part of the small intestine called your duodenum has a lot of strong hormonal effects. On the other side, the sleeve gastrectomy, it's called a sleeve because it almost looks like a long sleeve shirt sleeve where it has a seam down one side. The stomach is essentially tubularized, which again helps with the portion control. And that part of that stomach that in the one is bypassed and this one removed has hormonal effects by removing it. So they're similar, but different. So as you go up from the sleeve gastrectomy to the gastric bypass to the duodenal switch, the increase in their potency, or they become more powerful. One of the landmark studies still, even though this is several years old now, from 2017, was something called the Stampede Trial. And what was landmark about this was it was a randomized controlled trial, which in medical scientific terms is the most highest standard for determining that one thing is better than another or not. And this compared the diabetes outcomes, which that's one of the things we're most excited about treating, for people that had bariatric surgery versus really intense medical management of their diabetes and weight. And I think this first slide shows the change in the body mass index, which you've probably heard of. That's just a ratio of your weight to height. In the yellow line are the patients that have the best medical care, and they actually lost some weight. They lost, about 2 points of BMI at the 6-month mark, went slightly up after that because they were making a lot of good changes. You can see with the gastric bypass and the gastric sleeve that both of those had significantly more weight loss, with the gastric bypass being somewhat more powerful than the gastric sleeve. And then those people were followed up for 5 years afterwards. There was a slight slow regain of weight over that time, which is normal. If we follow people up over time, a small amount is relatively normal. Even more impressive, I think, and the point of this paper that was so exciting across not just the surgical but the entire medical community, was these changes in the A1C, which if you have diabetes, you'll be intimately familiar with this lab. It's really a measure of how well your diabetes is controlled. And that control of the A1C is really maintained very, very nicely 5 years out. In contrast with the medical treatment, it had really good effects in the first 6 months, and then it kind of went back up to the same old A1C level. Beyond just diabetes, really the effects of weight loss surgery are throughout the entire body. Obesity touches every component of the body, some in hormonal ways, others in physical manifestations like joint pain. And the point is to, at the very least, stabilize these other health issues, but hopefully prevent them if a particular person hasn't suffered from them yet. And in many or most people, reverse them to some degree, as you saw with those slides showing those tremendous improvements in the diabetes. And with that, I'm going to hand things to Dr. Cha, who's going to talk about the safety profile of weight loss surgery. Please keep submitting your questions. We're going to gather them all up and answer them at the end.
All right. Hi, everyone. Thanks for joining us. I'm Walter Cha. I'm a bariatric surgeon on the east side. Dr. Gutnick just spoke about how effective weight loss surgery can be in producing long-lasting weight loss and improving health conditions. That it's really the most effective treatment that we have available. And I'd like to spend a little time speaking about how safe weight loss surgery is currently. Next slide. Next slide. So when we think about the safety of weight loss surgery, we're really comparing the safety of weight loss surgery to the safety of usual care, which is typically non-surgical. I'd like to focus on 2 areas, the first being the risks of surgery, which will show are small, and the second being the larger health benefits that come as a result of surgery over time. Next slide. So where does weight loss surgery rank compared to other common surgical procedures in terms of safety? Cleveland Clinic did a study to answer this question, and what we found was that weight loss surgery, and specifically laparoscopic gastric bypass, had a similar complication rate to gallbladder surgery or hysterectomy, and a mortality risk that was only 1/10 that of open heart surgery. Next slide. This slide shows just how much more safe or safer weight loss surgery has become over time. Mortality rates for bariatric surgery have steadily declined over the last 15 years. There's been almost a 10-fold decrease in perioperative mortality since 2002. And some of the factors that have contributed to this are we've become more experienced with it. and surgeon and center experience. All of the Cleveland Clinic sites are designated comprehensive centers by the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program of the American College of Surgeons. And what this means is that we meet certain thresholds for the numbers of cases that we do and adhere to standards of care. And then the second big change that's occurred over time is that we've been able to use minimally invasive or laparoscopic approaches for the vast majority of our procedures. And so the summary is that the risks associated with weight loss surgery are small. Next slide. But the benefits of weight loss surgery in terms of health are large and real. And this is data from another Cleveland Clinic study that looked at the relationship between weight loss surgery and then major cardiovascular events, things like heart attack, stroke, and death, in patients who've had type 2 diabetes and obesity. And what we found was that for patients with type 2 diabetes and obesity, metabolic surgery was associated with a significantly lower risk of adverse cardiovascular events. There was an almost 8% lower risk of death at 8 years in the metabolic surgery group. And the surgery group had a lower risk of heart attack, stroke, atrial fibrillation, heart failure, diabetic kidney disease, and needed fewer medications for their diabetes and heart disease. Next slide. And this was all associated with a increase in survival. Next slide. So beyond just the benefits in terms of cardiovascular risks, there are a number of other health issues that are improved with weight loss surgery and that can lead to longer life. Treating obstructive sleep apnea and diabetes, the improved safety of childbearing, improving joint pain, which can allow a more active lifestyle and an improved quality of life, and decreasing the risk of certain cancers and treating fatty liver. Next slide. Obesity is a risk factor for severe disease in COVID. People with obesity who caught COVID were more than twice as likely to be hospitalized and almost 50% more likely to die of COVID. And weight loss surgery can modify this risk factor. Studies from the Cleveland Clinic showed that patients who've had metabolic and weight loss surgery had a lower risk of IC, intensive care unit admission, and were 60% less likely to have severe COVID infection. Next slide. This is more of that data. Next slide. Okay, well, thanks for giving me your time and attention. I'm now going to turn the presentation over to Karen Schulz, our program manager and one of our advanced practice nurses at Cleveland Clinic's Bariatric and Metabolic Institute. Karen?
Yes, thank you very much, Dr. Cha. Let's move to the next slide. I am, as he said, the manager of our program here at the Bariatric and Metabolic Institute, and we offer care as close to home as possible. We have regional centers centrally located at main campus, to the west at Fairview, to the east at Hillcrest, and in the south at Akron General. We are also actually in your home as we are right now. I would say many patients choose virtual visits. We can do up to 100% of your visits virtually. No virtual surgery as of yet, though, surgeons. But if you were working with your primary care physician, and we can get actual heights and weights, we can do almost all the program visits, if not all of them, up to the pre-op day in the comfort of your own home. So that's something new and exciting, really opening up access to a lot of people who might have difficulty traveling for in-person visits, which of course we also offer and really enjoy seeing patients face-to-face. Next slide. All right, when choosing a center for bariatric surgery, you know, we're lucky in Cleveland, we have lots of healthcare choices, but some of the things that make the Cleveland Clinic an excellent choice are some of the the distinctions that we have earned. In addition to being a center of excellence for bariatric surgery, the institute that we are part of, the Digestive Disease and Surgery Institute, is ranked #1 in Ohio and also #3 nationally. Main campus is #1 in Ohio, #2 nationally, Fairview #5, Hillcrest #4, and Akron General #7. So some really outstanding recognitions there, making us a good choice for care. Next slide. Now, as a new candidate for surgery, if you're just sort of thinking about coming into the program, there could be a little apprehension about getting started, navigating to all these visits. And so we know that at the clinic, we try to make it as easy as possible. And each of you would have someone, we call it patient navigator. So that's someone that would answer your questions, help you get started, coordinate appointments, make sure that things are timely. And they pull all of that information together at the end of your visit to get insurance approval for you before you actually have that operation. So there is someone that you can always reach out to. And next slide. In addition to the patient navigator, you have a specialist team. Okay, so you might say to yourself, well, how am I going to get through this huge program that does 1,000 cases a year? And that's because there's a lot of caregivers that are dedicated to the bariatric surgery program. So on your team, not only do you have your navigator, but you have a registered dietitian, you have an obesity medicine provider, you have a psychologist, and a surgeon. You will also have access to a variety of consultants if you need, sleep medicine, cardiology. We can also work with your physician in your hometown if you've had testing done. Don't necessarily have all of that repeated. We can work with your doctors. So you will not be alone. You have a team that gets you ready for surgery and will follow you afterwards as well. Next slide. All right, so as a summary, why should you choose bariatric surgery? And the answer really is because it works. All right, surgery is the really only consistently successful method to keep weight off. I know that many of you have been able to lose weight, but it's the keeping it off part that's so difficult, especially when you're suffering from a severe disease as serious as obesity, where your metabolism is slow, the calorie needs are very low, the body set point is high, and we know that dieting only has short-term results. We'll hopefully be able to help some of you, and we'll move on now to the next session. I don't know, Dr. Gutnick, if you want me to talk about how to connect with us before the question and answer, sort of as a final slide. I think that might be the final slide.
Yeah, and I think what a couple people have asked, what's the next step? So why don't we go over that now?
Okay, all right. I think we have a slide on that next, maybe, if I remember correctly.
Well, just to remind everyone, keep sending in your questions via the chat, and we're going to answer it.
Yes, yeah. So it's pretty easy. You go to Cleveland Clinic Bariatric Surgery site. You can just Google bariatric surgery. It'll come up at clevelandclinicweightloss.com. And then there is a big button on every page that says watch the seminar, which we recommend. So it's different than today. It's a little bit more program specific. You'll get to see pictures of providers and sessions, really learn a little bit more about what it would actually be like to be a patient in our program. There's a short registration questionnaire. Take your time with that. It takes about 5 minutes. And then after filling out that registration questionnaire, the next day, one of our navigators will check your insurance and send your case to scheduling. So within a day or two from filling out the seminar, you will be offered an appointment. It's not required, but if you want to watch a seminar and just wait, that's fine. Or if you will be offering you an appointment. And then from that point, your navigator sends a welcome email and you start coming to visit. So that's it.
All right, perfect. Well, I'm going to start off with a question for Dr. Cha. What are some of the things that you recommend to a patient to go for a bypass over a sleeve gastrectomy?
There are a couple of different a number of factors that we look at to make recommendations. One in particular is for patients with severe reflux disease or things like esophagitis due to acid reflux. The gastric bypass tends to be a better operation to treat reflux than the sleeve. In general, the gastric bypass is associated with a little higher weight loss than the sleeve. So in some patients who are on the higher end of the obesity scale, they may better be able to achieve their goals in terms of weight loss with a bypass over a sleeve. For patients who are on the really high end of the obesity scale, sometimes we'll actually recommend sleeve, though, with the idea of it being a staged procedure, or losing some, using the sleeve to lose some weight, and then down the road, potentially changing to a different operation to get to the weight loss goal. But a lot of it has to do with the individual in terms of reviewing their medical history and what their goals are. But those are some of the factors that we talk about.
Yeah, I think, one of the most important questions we always ask is, what's your goals? And that really helps us guide people as to what operation may help them get there. I'll answer this one. Have you performed any surgeries on patients with MS? And if so, are there any additional considerations? The answer is yes, there are. Not so much about the surgical procedure itself, but about making sure that we're totally coordinated with your MS physicians and to make sure your postoperative care is tailored to that. And that's really true, not just of MS, but of any other health issues that someone might come in with. Not only do you meet with the surgeon, where we talk about a lot of things Dr. Cha talked about, where we're trying to select what operation might be best for you. Some of that's about weight loss goals, other health issues, but you're also going to meet with obesity medicine specialists and then any other specialists that are needed to really tune you up for surgery, as it were. So it's not everybody, but it's certainly common for people to need some tune-ups to get ready for safe surgery. It's extremely rare for someone to be quote unquote too sick for surgery. But it's not unusual or rare for someone to need to tune up to make sure it's as safe as possible. And that's part of the reason why we can sort of boast about the safety of bariatric surgery, is we're very attuned to that. Karen, if you could answer some of this and maybe talk about some of the requirements. Is there a minimum weight you need to be as a requirement for these operations? Are there any other requirements?
Yeah, so generally, people who think about bariatric surgery are going to be a BMI 35 and above, roughly 100 pounds overweight and higher, depending on how tall you are. Additional requirements, well, let me go back one step. So BMI 30 to 34 would also be considered for surgery, especially if you have some health issues. But the one challenge that we have is sometimes insurance companies don't agree in those lower BMI ranges. So then we're looking at, potentially people that might want to self-pay for surgery. Other requirements, sometimes your insurance company, and we'll find this out when we check, might require a preoperative medically supervised weight loss program, which you can do with us. Come into the program, see all the providers, sort of like queuing up for surgery, but you spend a few more months with our dietitian based on insurance requirements. Some of those insurance companies do require a certain amount of weight loss, not all of them. We just ask everyone to do the very best that they can. And we'll guide you too once we check those requirements. The other requirements are, is what Dr. Gutnick mentioned, is, as we tune you up for surgery, there may be some medical conditions that you aren't aware of right now that need to have treatment. So for instance, you may have sleep apnea, and your obesity medicine physician will be screening you for that, potentially ordering some testing and then having you receive treatment. If you already have sleep apnea and it's treated, then you just kind of miss that step. So anybody out there that's having difficulty sleeping right now, perhaps really sleepy during the daytime, if you wanted to get a step ahead of things, you could see your primary care doctor and inquire about getting a sleep study. Yeah, I don't know if anybody else has anything else to add as far as requirements. We do want you to be educated by all of those people on your team. Make sure you understand how to eat after surgery, and that you're as stable as possible from a medical standpoint. Yeah.
Yeah, the only thing that I would add is that several years ago, a large group of international diabetes organizations came together and recommended decreasing the BMI requirements for patients with diabetes. And some insurance companies have gone along with that expert recommendation, this international panel of expert recommendations, but not all have. But since then, it's become much more specific to different insurances. So if you may fall into that category, you should contact your insurance company and see what they cover. And most of them post it online. But you can also even call them and check for your particular product. And as Karen said, also there's the option of self-pay. Speaking of which, Karen, I'm going to throw another question at you because someone else asked about what the process is for self-pay if someone's interested in it.
Yeah, if you are interested in self-pay, you know your insurance doesn't have coverage, then you just come into the seminar the same way. There's a little option drop down for self-pay, and then our financial counselor will give you a call and let you know those details. She's asked me not to give quotes at the seminar. She'd rather talk with you personally.
Perfect. I'm going to throw a question to Dr. Cha. I had the lap band in 2008, and it was frankly a disaster, and it was removed. I don't want to try surgery again. Can I try medications first? And then what are my options if I do want to pursue another bariatric operation? Maybe you can talk a little bit about why we don't do bands anymore as well.
Sure. You know, what we found over time is that the longer patients have had adjustable gastric bands, the kind of higher cumulative rate of complications. So, meaning patients at 1 year, very few of them had problems, but as you followed them out year to year, when you got to 10 years, a significant proportion of patients had issues, usually related to kind of the stomach tissue moving underneath the band and creating problems. So the majority of them, now are, the procedures that we do with bands are really just to remove them. And absolutely, one of the advantages of being in a comprehensive program is that we have a wonderful group of obesity medicine providers. And if you're not ready to take the step of coming to surgery, they're able to work with you and, work with you from a diet perspective and add medications where they're appropriate. For patients who, decide that they, have their band removed or want to have their band removed and then still have some kind of bariatric surgery, we most commonly do them in stages, meaning remove the band, allow some of the scar tissue around the stomach to go away, and then convert patients to a different bariatric procedure, usually either a sleeve or a gastric bypass.
Perfect. I'm going to answer a couple of administrative questions. One was, what about Cleveland Clinic, Florida? They're also an excellent bariatric program. It's a separate program from the ones that are across Northeast Ohio. But if you're somebody that lives part-time in Florida or part-time here, I have no doubt that we could arrange either surgery in one or surgery in the other and follow up in one or the other if you're have a snowbird type situation or some other thing like that. So they're separate programs, but we'd be more than happy to take care of you if you had surgery there, and likewise they'd be, I'm sure, happy to take care of you if you had surgery up here. Another sort of question that several people asked, and I want to harken back to the part that I was talking, the slides that I kind of went through about why bariatric surgery works. Several people have asked, why do people either gain weight or regain weight? Or after surgery, or why do people gain back weight after dieting, but surgery they don't typically regain as much? This question has been asked in several ways. So our bodies have a hormonal set point, and it's sort of like, the best example I can think of is that it's sort of like a thermostat in your house, where you set a temperature and your heater and your AC either turn on or off to keep you at that point. And your body works very similarly using your hormones. So if you're trying to diet, your body turns down your metabolism, and bariatric surgery almost short circuits that, if that makes sense. And so it turns your metabolism up after surgery. These effects from the bariatric operations are extremely powerful in the first period of time after surgery, and they decrease over time. So for the first year or two, they're extremely powerful, and then they start to tail off. So the surgery is a tool for weight loss, but in terms of weight maintenance, it's really, and the reason I think that Jamie really harkened on about follow-up is that we want to follow you carefully, so that if you are having weight regain, you identify it early and treat it by figuring out why that may be happening. It might be from a problem with the operation, or maybe with the amount of exercise, etc. Part of it's going to be those long-term changes to lifestyle. Part of it is the operation that's chosen. As you go up in strength of the operations, the chance of weight regain goes down, because the stronger the operation is, the longer it persists being strong. So those are some of the reasons why. And if you have any particular concerns about that when you meet with your surgeon, you can talk those over with them. So I'm going to put a question to Jamie. A couple of people have asked, is it possible to enter the program to do medical weight loss? And if you do that, how do you, and you decide you want to go with surgery, how do you switch over?
So yeah, actually I work with the medicine team. So we actually have patients that do this on a regular basis. As Karen was talking about, there is that some patients, their insurance requires the 6 months of medically supervised weight loss, or a certain number of months. So sometimes we'll have patients that kind of still work towards that, but kind of hand in hand with medicine. The medicine provider is going to be the same provider, whether you want surgery or if you want non-surgical options. And so just kind of having that conversation with them, and they can kind of start you on both actual parts of that program by, discussing a medication with them, or maybe some diet and lifestyle interventions that you want to work on first. You would still meet with one of our nutrition providers, and then kind of go from there, while still trying to fit in some of that criteria of things that you'll, need to work on in order to have surgery, if that's something that you still want to do. But, even going through our program, you're not 100% committed to surgery at that exact moment that you register. You can still work through our program, do what your insurance requirement is, and then should you decide through that process that you've been successful losing weight, you would just want to let your the medicine doctor know that you're, going to hold off on surgery, or let your patient navigator know that, hey, I'm going to hold off. This is really working well for me. Or if you decide you don't want to register for the surgical program at all, there is still the surgical option, or the non-surgical option, of just meeting with one of our obesity medicine specialists. We currently have 8 obesity medicine providers on our team that work with patients for both surgical and non-surgical options. So a good group of providers that are really knowledgeable about just helping patients either way, either path. We're working for you to help you meet your goals. So there's good options for you either way.
And, Jamie, one person asked if they were already doing the medical program and they wanted to switch to surgery, how did they do that?
So similar concept. Ultimately, the best thing is, even if you've already been working with one of our providers for medical or working with a provider for medical, that is good. You would just still go to this clevelandclinicweightloss.com and you would register for our surgical program. And then they can double check your insurance, make sure you still have, the insurance coverage for it, or what maybe needs to happen with that. And then if you have been seeing somebody already for medically supervised weight loss, sometimes we can use some of those visits to count towards that medically supervised weight loss that your insurance may require. So it kind of goes hand in hand. We can kind of work with you on that, but registering for the surgical program is how you're going to get that ball rolling.
The one other thing I'll mention is we also have a separate group that does a really good job with medical weight loss within the endocrinology department. So if you had any difficulty or it wasn't obvious how to switch over, it may be because you're with the endocrinology department, which don't offer a surgical option. You could either talk with that specific physician that you've been working with and just ask for a referral, or you can simply go to our website and put your own information in if that's your situation. I want to take this one, this question, because it's interesting. I've heard this a lot as a question from patients in my office recently. So the question is, I follow a bariatric weight loss group online, and I hear about side effects often of people needing IV nutrition, not being able to keep food down. How often does this happen? I'll let you know that, and this is purely based on my own talking to my own patients. Recently, there's been a lot of patients asking about this. They've been following some people that are trending on Instagram who are almost bragging about how they feel terrible after surgery. So this should be, this can happen. It's really unusual for this to happen. You should not feel terrible after surgery. I think Jamie is a really good example of a typical person, how a typical person feels. Her story is very typical, where you have a 1 or 2 day hospital stay. Then you go home, you're doing some light walking and learning your new anatomy in the first couple of weeks, maybe some mild nausea, but often not much with the liquid diet. And then you slowly advance your diet and you don't feel really bad during any parts of this. That's how it should be. With the ultimate goal of eating smaller amounts of regular food with a focus on protein over the long term. And that's what our goal is. It's not to be on some sort of fad diet or special or unusual diet over the long term. And so to summarize that, occasionally people need some IV fluids. I can tell you in my own practice, it's a little more frequent than 1 in 50. So it happens, but it's unusual. And we track that very carefully. And I think it's very similar among our other surgeons. So again, it can happen, but it's not typical, and it's not to be desired either. It's not what we're shooting for. So hopefully that answers the question and allays some people's concerns. Jamie, from you're talking to patients, and maybe we can all chime in on this. Is there a difference in the amount or the type of food that you can eat with gastric bypass, duodenal switch, or sleeve gastrectomy?
So I actually have a friend that had a sleeve. I will say, with talking with her after she went through the process, and then myself, who I had the gastric bypass, initially, not really. You have a little bit of like internal swelling within that first 3 months. And that's why I was mentioning in my slides, food's not like, you're not eating for fun during that time. So I really am not I didn't notice that with each of us initially post-op wise. I do notice with her a little bit more frequently now that she's outside of surgery, and this is anecdotally, that she does, her hunger cravings maybe come back a little more regularly. And I had the gastric bypass, and sometimes I myself have to like remind myself, oh my gosh, it's already like 11 o'clock and you hadn't had breakfast, or you haven't done this, and like you haven't eaten today. So, for me, I'm more of a type of person, I just have to continuously remind myself like, hey, you need to get your protein in. Hey, you need to eat. And so I have to be more on track of my eating habits as opposed to like how much more I can eat. I am eating a regular portion size when I do eat in general, but that's a real portion size, not like we talk about like American portion sizes, which can be pretty big. So when I go out to restaurants, I always have leftovers. When my husband makes me food, he's still making me like what I used to be able to eat sometimes. And I'll come into work and I have this huge bowl of food and I'm like, my husband packed my lunch. And so it's, I do eat less, but if you actually look at what a real portion size is, I feel like it's similar, close to an actual real portion size, sometimes a little bit less, but it again just kind of depends on how heavy the food is, how lean the protein is, and kind of how it sits in your stomach. But I have noticed with my friend that she's able to eat a little bit more. She has a little bit more hunger. I don't know if Dr. Gutnick, you could kind of comment on that sleeve versus bypass.
Yeah, Dr. Cha, I don't know if you wanted to chime in on some of that, not just anecdotal, but I think there's, difference in the outcomes between sleeve and gastric bypass, and I think this is related to it in part.
Yeah, when I meet with patients, I usually counsel them that with the sleeve, the weight loss is slightly lower long term. I usually tell patients that the average patient would lose 40 to 60 of their excess body, 40 to 60% of their excess body weight loss, which translates to about a quarter of their pre-existing body weight. While with bypass, it's usually 50 to 70% of their excess body weight loss, or closer to a third. And in part, it may be attributable to the addition of the malabsorption with the bypass, but when we create the sleeves, we try to remove what's called the fundus, the upper part of the stomach that we tend to think causes patients to be hungry. But over time, the stomach that's left, it's made of predominantly smooth muscle, so it will stretch out over time. And so we really try to counsel patients, even though they feel that as they get further out from their surgery, even though they feel like they may be able to eat more, to really use their visual cues to know how much they can eat before they feel full and stop there, rather than continuing to eat till they're all the way full all the time.
Yeah, and the only additional thing that I would say is that, yes, I think that people in general do eat a little bit more after sleeve gastrectomy over the long term. And one of the reasons, and this gets a little bit in the surgical history, and I don't want to spend too much time on it, but when you look at how the duodenal switch was designed, originally the sleeve was just a part of that operation. And this was with a slightly larger stomach than the current sleeve, the way we perform sleeve gastrectomy currently. But it was purposely made so that people could eat slightly more food than with gastric bypass, because there isn't more of that malabsorptive type component to that operation. So the people that designed that operation wanted people to eat slightly more than a gastric bypass. Now, sleeve gastrectomy is, when that's performed, it's made smaller than the sleeve that's a part of a duodenal switch, but it still is probably a little bit more than gastric bypass. So it's partly in the design of it. I have a question for, I'm going to direct it at Karen Schulz. Do these operations actually cure PCOS and diabetes, or do they just make them easier to manage?
Yeah, so I think the word that we usually say is improvement or remission. Some of it depends on how long you've been a diabetic. If you've been on insulin, and doctors, please update this, but it's usually 5 years or more, chances are it will be an improvement in your diabetes, but not necessarily a cure. We don't really know till you lose all the weight. If you've been on insulin 5 years or less, you have a better chance of having remission of your diabetes, or maybe just needing oral pills instead of insulin. PCOS, normally that The symptoms is what we see improving after PCOS, not necessarily having the disease be gone, but having the symptoms be gone, sort of like a remission from those symptoms. Anything to add there, Dr. Gutnick?
Yeah, the only other thing I would add is it also really varies, as you said, where you start and then which comorbidity you're looking at. So, for example, obstructive sleep apnea, we see a significant improvement or a complete remission in most people or many people, depending on where they start. Actually, the reason you have obstructive sleep apnea with obesity is you actually weight gain in the back of your throat, and that's one of the first places you start losing weight. So often patients feel that's one of their first improvements they feel. And that may not have to do much of anything with how long you've had it. Whereas with diabetes, the pancreas gets kind of worn out the longer you've had it. And so the time you've had it and then the amount of medications that you are on to have control will tell us how much you'll improve. I'll answer the next question. Do we perform, and several people have asked this, what about the balloon procedure? You didn't talk about that one. So we didn't talk about balloon procedure because it's not actually bariatric surgery, although it is a method for weight loss. Cleveland Clinic does offer it, and we can direct you to if you register with us, we can direct you to the appropriate people if you're interested in it. It is currently, I believe, under all insurances, still a self-pay option. The reason it's a self-pay option is it's never been proven to be effective for long-term weight loss. So that's why most insurance companies haven't approved it, because they haven't seen that it is effective over the long term the way they've seen for surgery. So it is an option. It is performed at Cleveland Clinic, and if you're interested in it, so just sign up and we can give you more information about and direct you to your consultation with the appropriate person. Question to Dr. Cha. If I've had the sleeve and I've had some weight regain, is it an option to perform revisional surgery? I'm on the fence.
Yeah, revisional surgeries are an option for patients who've experienced weight regain or inadequate weight loss with their primary procedure. I think the first, usually we'll have patients be evaluated by the full team, and oftentimes working with obesity medicine will and perhaps starting some of the weight loss medications would help patients get back on track, and working with the nutritionists and our psychologists to try to identify some of the factors that led to the weight regain. If that is ineffective, then there are different options depending on what previous surgery you've had done. For patients who've had sleeves with inadequate weight loss, they can be converted either into a gastric bypass or duodenal switch, to try to achieve additional weight loss.
Perfect. And I'm going to just let everybody know that I think most of the panelists are going to sign off because they have other clinical duties to get to. I perused our questions to make sure we didn't miss any, and there were a couple that I wanted to address. One is there literature about the body set point and how surgery resets that? The answer is yes. There's a tremendous amount in the scientific literature. It is incompletely understood. So if you're going to review it, I would recommend that unless you have extensive understanding in endocrinology and biochemistry, not to get too bogged down in the details, because it is an extremely complicated system, partially understood. All that being said, we do know that from taking care of many, many patients over time, both with personal experience and with the science, that bariatric surgery is effective for the long-term weight loss for most patients. But yes, you can peruse all those things. I would just say don't, unless you're extremely scientifically literate, it's hard to make sense of it, because it is so vast and so complicated. And then several people asked about time to surgery from the initial presentation. That's going to vary on three things. The first thing is it's going to vary if you have any mandated medical weight loss from your insurance company. Many people do not anymore. Some people have 6-month weight loss that they're required to perform, so it's going to be a minimum of 6 months. Similarly, it's going to also vary if you have very many other health issues. We talked earlier about getting tuned up for surgery. Sometimes, especially if people have significant lung issues, they may require more intensive therapies from their pulmonologist to get ready for surgery to be safe. That's just one example. So that may extend your time frame. Some people may not have necessarily seen that many doctors, although they may have some comorbidities. So that can slow things down a little bit too, because you have to once we identify those things, get those issues identified, diagnosed, and treated, and that can delay you. If you're someone that doesn't have really any other health issues, don't have any insurance requirements, or your health issues are already identified and well treated, anticipate a couple of months. During that time, you're going to see the entire team, so surgeon, obesity medicine specialist, psychologist, and registered dietitian. All those people are going to make sure that you're totally prepared to really thrive after surgery. And so that process takes a couple months. I think that answers all of our questions. We are going to review them at the end so that hopefully if there's any we can miss, we can get them answers back to you. Thank you everybody for attending today. And we look forward to meeting you in person or on a virtual visit.